Hi, everyone. I'm Julie Wittman. I'm a BCBA from Lewiston, Idaho, and I'm also the parent advocate on the panel. I have a 12-year-old daughter with autism.
Great. Thank you, Julie. So let me pull your slides up and
Yeah,
then you can just let me know when to progress.
great. So welcome, everybody. Today, we're going to take kind of a deep dive into the Katie Beckett and Developmental Disabilities Program that are available to children in Idaho. So we can go to the next slide. Our objectives today are to kind of look at an overview of the Katie Beckett program and then look at the Department of Health and Welfare's Developmental Disabilities Program, kind of making some distinctions between the support side and what's available to children with autism, and then the intervention side and what's available. And also there's a behavior modification through Magellan on the behavioral health side. Next slide, Lindsay. So Katie Beckett was a girl who was hospitalized from infancy. She was put in the hospital to receive ventilator assistance following a viral encephalitis infection that left her partially paralyzed in a way that affected her ability to breathe. As she became recovered from that, her parents were told that she had to stay in a hospital or an institution for Medicaid to cover the cost of her services. If she were to go home, her parents were then going to be responsible for the cost of care. And so her story was picked up by the Reagan administration, and they looked at ways to deregulate and reduce the cost of Medicaid. And so Katie Beckett waivers are now something that's available in different states. It's kind of up to each state to determine if they have a Katie Beckett waiver or not. And I'm really proud that Idaho does have a Katie Beckett waiver because some of our neighboring states do not have that. And these waivers allow Medicaid to cover those medical services for children in the home, regardless of the parent's income. And a lot of times these are cases where home-based treatment will cost less than or the same treatment as a hospital. And so this has allowed parents basically not to go broke trying to cover the cost of care for their children when they could keep their children at home. So this is a really amazing thing that has come about and that the state of Idaho has to offer. So next slide, Lindsay. Within the state of Idaho, the Katie Beckett Medicaid program has a website. And on that website, you can explore that more to learn more about it. But it is a program for children, again, who are living at home with long-term disabilities or complex medical needs. And if they are eligible for Medicaid services based on their child's disability, they can receive those even if their family income is above Medicaid federal poverty guidelines. And in these situations, it's only going to be the child with the disability that will qualify for Medicaid, not the whole family. And if the child themselves on Katie Beckett makes that $2,400 gross before taxes, it can affect the child's eligibility. So if the child has an inheritance or a GoFundMe account or things like that, that can impact their ability to qualify for Katie Beckett. So it is something to consider as you're coaching your parents, looking at what assets their child has and whose name that it's in, and all of that can impact whether they are eligible or not. So the child must qualify based on income and diagnostic criteria. So it's a two-pronged eligibility. Next slide, Lindsay.
Just a quick question, Julie. You had
Yeah.
mentioned, so from the chat, Hadley Goff is asking, in other states that do not, or that do have a Katie Beckett waiver, do they call it Katie Beckett like Idaho or something else?
Oh, they might call it something else. In most cases, there's some reference to Katie Beckett, but yes, it could potentially be called something else. I don't know off the top of my head what they might call it. It might be just called a waiver service, and they might not specifically call out Katie Beckett in the title of it. But it could be called something else. Yeah. Tom, did you have a question?
No, I had done a quick search, and it is not called Katie Beckett in other states. It it has no reference. It's really Tephra in a lot of states, but there's like Connecticut calls it Katie Beckett. Very few call it Katie Beckett. They all have some persons with disability, health and wellness waiver, other things. I put a link in the chat to the kids waiver
Oh,
list.
perfect. Thank you.
I learned something new today too. Thank you.
I did too. Um, so within Idaho, the Katie Beckett diagnostic criteria, the child must have a developmental disability or a complex medical need, which could include a physical disability. Both of those require documentation from the primary care provider. So that's where all of you come into play, requiring or supplying that documentation for families. So developmental disabilities are defined as a developmental disability diagnosis might include autism, intellectual disability, cerebral palsy, a seizure disorder, or Down syndrome. And under those different categories, at least 3 substantial functional limitations have to be demonstrated that meet that intermediate care facility level of care. So this level of care is much higher than just having a developmental disability. So we're looking for significant delays and or maladaptive behavior that would indicate the child qualifies to live in an intermediate care facility for individuals with an intellectual disability. So they have to meet that standard in order to become eligible. And they also need to demonstrate that lifelong or extended duration of services. Next slide, Lindsay. So under this diagnostic criteria, the complex medical need or physical disability definition is a chronic condition. This might be a condition that a child has that has met the Social Security SSI income criteria. So in the process, like when I went through it for my child, we applied for Medicaid in general, checked the box that somebody in our household had a disability. And then we also went to Social Security and applied for SSI. We got denied, and then we go back up to the meeting the eligibility criteria for the medical side. But if the child does meet the Social Security income criteria, they will likely meet the criteria for Katie Beckett. The child requires a level of care provided in a medical institution. The child's physician has completed that evaluation, identifying services necessary to maintain the child at home, and it has to be safe and appropriate to provide care in the home. And I remember when we were going through this process, I was a little bit caught off guard that like, oh, my child could be put in an institution. Like, what does this waiver mean? So as care providers, it might be helpful to set parents up like understanding what that means, not to be scared by that. What does it mean that I'm signing a waiver? That means that my child is not going to be in an institution, but I'm going to care for them at home. I remember that being a little intimidating as a parent when I was signing those things, just hearing that they met that level of care that could be in an institution. So that can be a little scary language for some parents. Just a heads up. Next slide, Lindsay. So the process to go through to get Katie Beckett Medicaid should begin by gathering all of the medical and diagnostic documentation prior to applying. It's going to be much easier for the family to answer all of the questions if they have a binder put together that has all of the treatment notes, any reports from assessments that have been done, like the STAT, like the ADOS, anything that they have that has any kind of diagnostic information, putting that all together in a binder to bring with them or to have available as they're filling out information online is really important. So helping families get organized is something that you can do to support them. Also, there is that 2-pronged eligibility. So they're going to have to go through that financial eligibility first by applying through Self-Reliance, which is the Idaho Medicaid, where you go to get Idaho Medicaid. And when you are filling out that application for Medicaid, you're going to indicate by checking a box that someone in your household has a disability. And that's what's going to elevate it up to the Katie Beckett. It's also helpful if you're doing it in person, just to tell them that I'm interested in Katie Beckett Medicaid for my child. They have a disability. And then that second step is the level of care. And that's going to be done through an assessment by an independent evaluator through Liberty Healthcare. And so they will go through a process over the telephone, usually, or a Zoom meeting, where a Liberty Healthcare assessor sets up a time with the family. They're going to go through the Vineland and or a nurse review and talk through all of the eligibility criteria and do that assessment with the family. And they have about 10 days to return the Katie Beckett application. That is not a lot of time. So it's really important that families who have a lot on their plate understand that this is kind of a tight timeline and that there might be quick turnarounds required from them. So that's another thing that we can do to support families, is to help them know that they have to stay on top of this process. Next slide. So timelines, again, and responsiveness are critical from our families. If you miss a phone call from Liberty Health and they try and reach out again, they're not going to reach out 4 or 5 times to schedule that with a family. So they really need to be responsive to any messages left from Liberty Health in order to get that evaluation scheduled. And also the timeline. Right now, it takes quite a while to get on Liberty Health's schedule, and sometimes it takes several months to get that interview done by Liberty Health. So it's really important to follow up on that and be responsive so that you can get this process going. It's also important to keep any demographic information updated within the Medicaid system. And if a family applies or starts their application for Medicaid and it takes a little while for them to get approved, that Medicaid coverage can be backdated 90 days if it's requested from that initiation of the application. So that's good for families who maybe have gone through a lot of medical testing, things like that, that's not covered by their insurance company. It's nice to know that Medicaid can be backdated if they request it. When you receive Katie Beckett Medicaid, the family can be charged a premium based on income, but they can opt out of that. However, there are some copays, which are not optional, and that typically will apply to speech, occupational therapy, or physical therapy. And then every year there's a financial redetermination, and every 3 years there's a diagnostic redetermination required to maintain that eligibility in the Katie Beckett Medicaid program. So it's good to prepare parents that they're going to be contacted every year by Liberty Health just to touch base, make sure nothing's changed. And every 3 years, they're going to have to go through that more extensive Vineland evaluation. Next slide. So Katie Beckett Medicaid is always secondary to any primary insurance that the family is going to have. But families are not required to keep a primary insurer. For some families and some children, Katie Beckett Medicaid is the only coverage that they have. But it can also be secondary if you have a primary in place. Katie Beckett Medicaid covers almost all services that other types of Medicaid covers. There are just a couple of exclusions, including residential treatment, even through the EPSDT process, and also that preventative health assistance or weight management benefit that's available to other Medicaid programs is not available to Katie Beckett. So there's just those couple of exclusions in terms of coverage. Next slide, Lindsay. So now I'm going to change gears and talk a little bit about the developmental disability program. it's really important to know that in order to access the developmental disability program, a child has to be covered under Medicaid. So that's why we talked about Katie Beckett first. The developmental disability program through the Department of Health and Welfare doesn't provide direct services. Those are provided through developmental disability agencies and independent providers. So there's a list of those for each region of the state that's on the Children's DD program website. And it's also something that you can ask case management to help you with identifying providers if you get accepted to the DD program. So that's the next point. The DD program can provide case management, and I'm a big advocate of case management because they are often the people who know what providers are available, who know who's got openings, and they can help access different community services. They might know about programs that the family doesn't know about, and they can help make referrals and monitor those needed supports and services. So we love our case manager, and I would recommend case management to other families. Case management is also something that can be provided while the family is going through the process of getting Katie Beckett Medicaid. If the family needs more support as they're going through that process, that is something that's available. So that's the third point there, that case management can help support families in applying for DD services, and it can be provided prior to that eligibility for DD services. This is great for families who need a little extra support, who might need language assistance, or for those families who are in the infant toddler program. So I'm a huge advocate of getting them set up with case management as they're going through this process. Case management can also kind of see from the inside if they've been contacted by Liberty Health, and help facilitate that timeline and responsiveness with families as well. Next slide, Lindsay. For referral to the developmental disabilities program, you can refer families by faxing a referral form with notes from any primary care provider to any of the regional hubs for the Department of Health and Welfare. For other providers, the DD referral form can be used, and families can also apply directly through the developmental disabilities website, which I think once this link is included in our session, then you can access the links from this through those session notes and resources, right, Lindsay?
Yes, and we'll just put a direct link to this on our session resource. So when you come to our ethos page and there's that overview for this particular session, any of the resources that Julie's mentioned today or that are offered in the chat, we'll put those in that on that page. And if you have questions on how to access that, you can reach out to myself or Hongyan.
Thank you, Lindsay. Next slide. So there's a website specifically for children's developmental disability services that's going to delineate all of these procedures and different services that are provided. All children's developmental disability services do require Medicaid. There's actually a pretty large menu of services that might be available depending on the child's age and diagnosis. One of the things that we want to make sure everybody's aware of is that wait lists are in place for most services in most areas. And so that can be a little bit tricky. I always tell people to get on the wait list if they're wavering back and forth, because you can also always cancel an appointment later on, but getting on those wait lists is really important. So for initial families with a developmental disability diagnosis like autism and Medicaid, we would recommend applying for DD services through the online application, and having a case manager support the family in accessing their best fit in terms of what services are available and might fit their family the best, depending on their individual needs. So that would be our where we would recommend going first. Yes, somebody said in the chat, the developmental disability services application can be and is usually submitted at the same time and through the same process as the Katie Beckett Medicaid application. That is true. And you always want to note to the Liberty Healthcare assessor that you are interested in both Katie Beckett Medicaid and the developmental disabilities programs so that they can be doing that application for both programs and you don't have any extra wait time. So that's a really great point. Thank you, Anne. There's a distinction in services under the developmental disabilities program. One part of it is called DD supports. The other side is intervention. For the developmental disability supports, this is going to be available to any child birth to 18 who has a diagnosis. The same set of diagnoses are in play here: autism, cerebral palsy, seizure disorder, Down syndrome, intellectual disability, or closely related disorder. Families must apply with documentation of a disability for DD supports. And again, this is going to get evaluated through Liberty Healthcare. So they will do an interview and also the Vineland. And this can be the same Vineland that's done for the Katie Beckett process if it's a new family. Right now, it's about 60 to 90 days to get through the whole application process. And if you have questions, here are a couple of phone numbers that you can call for the support side. Next slide, Lindsay. For the supports that are available, these are not services that are meant to teach new skills. That's where the intervention side comes into play. Supports are more provided to practice those skills that you might have gained in intervention and also provide caregiver respite. So supports that we have also been to allow the child to participate in like community events or classes that a child might take in the community. Those supports might look like a community support worker who goes with your child into the community to an event or to the library, to story time at the library. You know, it could be helping them with emotional regulation while they're at that event. It could be going anywhere in the community, like shopping at the grocery store, things like that that are often difficult for our children with autism to access. That's a support that's available. It also could look like goods to help them with that. My child uses a scheduling app that helps her know what's coming next to increase predictability in the community. We also have some emotional regulation apps on an iPad that helps her access the community. So there's a lot of different ways that you can use a supports budget for your child in order to help them both at home and in the community to practice those skills. And also the respite is really important for a lot of our caregivers. Children who do qualify for supports are then assigned a case manager who will help them figure out how to use their budget. And there is annual eligibility with Liberty Health required for the supports every year. Next slide, Lindsay. I apologize, the smoke from the fires is getting to my vocal cords. If a child does qualify for supports, then they're given an annual budget, which is either on the low end, $4,900 up to a high end of $14,900, depending on their individual level of need to use for their support services. Families can either choose to go traditional or family directed in terms of how they're going to spend that budget. The traditional pathway is a way for them to access these services through a developmental disability agency or an independent provider of supports. And those services would include family education, respite, and those community-based supports in terms of a person that will go with them to those different events. This is really good for families who have a hard time with a lot of paperwork or managing a lot of things, or who have an agency that they really like to work with. There's also a family-directed side, where the family has more autonomy over selecting how they're going to administer the budget. This is the only route that can access goods or services, that can access goods. And there's more flexibility with the family-directed side, but there's also more responsibility and paperwork on the part of the parent. So this can be a tricky decision for some families to decide which route to go. And I think a case manager can be really helpful in making that decision in terms of how they're going to approach this. But this whole process can be kind of overwhelming. So that's why I advocate for case management to help explain it, because there's a lot of different pathways that families can go down to access supports and services. Okay, Lindsay, next slide. So the other arm of services that are available through the Developmental Disabilities Program are interventions, behavior interventions. These are available birth through the month of their 21st birthday, so a little bit longer than the support side. And eligibility is based on a functional and or behavioral need, again, determined through the Vineland. Services are provided through an independent provider or a developmental disability agency. And this is going to be where we're building skills, where we're looking at decreasing challenging behaviors on the behavior intervention side and skill building on the habilitative skill building part of it. There's also crisis intervention that's available for families through the intervention side and interdisciplinary services. And what that looks like is if you have a child who maybe is having a lot of behaviors during their speech therapy session or their occupational or physical therapy session, one of these providers from the DD program can go with them to that session, bill interdisciplinary services while the provider's billing speech, and they can help network with that provider, showing them different strategies for behavior that might help make the session go smoother, while at the same time learning about what the goals of speech or occupational therapy are and supporting that provider outside of therapy time with collaboration on the same goals. So interdisciplinary service is something that's really nice for providers to collaborate together with. So that's something that's also available through the intervention side of the DD program. Next slide, Lindsay. To access intervention, you do not have to have a supports budget. You can do intervention only, but it's nice for some new families to have access to those supports to determine their best fit for services. If the child is accessing intervention only, case management is optional. And all of the authorizations for intervention are through Telegen. Parents are going to get a copy of that authorization, so they might be confused why they're getting something from Telegen. It's just telling them how many hours have been approved for what service through the intervention side of the DD program. But I've worked with a lot of parents who are confused about receiving letters from all these different agencies and sources. So sometimes it's helpful to sift through them and let them know all of the different options and what they're accessing. Next slide. So there's also another service that's available through Magellan, who is the new provider of behavioral health service in the state of Idaho. They have replaced what was Optum in the past. So behavior modification is something that's available, which is separate from the DD program. It's not a DD service. Providers are enrolled through Magellan, and it's through the ABA model. So a BCBA or a BCABA or a registered behavior technician are going to be who is actually providing the service. And so it is possible that a child could receive both behavior modification, and access DV services at the same time. You don't have to do one or the other. There aren't a lot of BCBA providers in the state, so if you are looking to support a family to get behavior modification, it might be helpful to contact Magellan and find out who their providers are who are contracted with them to provide behavior modification if you're looking for a list of providers. Next slide, Lindsay. So again, all of these resources are going to be available in links on the session resources site after today. But what questions do you have? I see a comment in the chat that if a parent gets into one of those supports pathways like traditional, they can switch once per fiscal year to the other support pathway. So if they want to go family directed and they started out traditional, you can only change once per fiscal year. That's right. But it is an option to change too. Maybe you get down the road in the family directed and it's too much for you. It is possible to change back to traditional. Tom, did you have a question?
Yeah, I saw a comment that within the 10 days of application time, a visit with their physician is required. I thought it was just that they had to get the physician record ready during that 10-day period, not actually a physical in-office visit, because that would basically exclude almost all patients from accessing it, just because, like you mentioned, autism, and suddenly everything, you get a wait list way down the road for a longer appointment time. So I just wanted to confirm that you just have to have that information from the doctor with the diagnostic, assessment in it, rather than actually a in-person visit.
Yes, it's my understanding that you have to turn the application around in 10 days. I don't think you have to have an actual in-office visit with the provider, but it is a tight turnaround.
I haven't been doing that.
It is a tight turnaround to get the paper.
Yeah, thank you.
Elena had a question.
Yeah, do you know what the diagnostic requirements are for behavioral modification through Magellan? And then a follow-up, does the child have to have an autism diagnosis?
So I don't think the child has to have an autism diagnosis for the behavioral modification, but you do have to meet certain requirements. It will require, they have to, no, I lied. They do have to have an autism diagnosis for behavior modification, sorry, because they have to have proof of an assessment that is norm referenced for that. Because as a provider, I've done this through what was Optum, and we had to have like an ADOS or a STAT or something that is you can't just have a diagnosis provided by a pediatrician without some kind of an assessment that's been done. And then, go ahead.
Sorry, Julie, I'm just going to ask a follow-up question. So was this something that Optum was providing and now Magellan is too?
Yes.
Or is this something new? Oh, okay. I was not aware. What did Optum call it before?
The same thing, behavior modification.
Behavior modification. Okay. So have to have an autism diagnosis. Okay. Thank you.
Yes.
Thanks. Gwen, I see your hand up.
So Julie, a question about the copay for primary insurance. Would Medicaid pick up that copay? Do you know?
Yes.
Okay.
Typically, Medicaid does pick up the copay.
Okay, so then I have two more things. Case management. Does the case manager, is she or he paid, or is that something that's provided by the state?
That's something that's provided by the state. They're paid by the department. There's some that work directly for the department, and there's some that are contracted by the Department of Health and Welfare.
Okay, and then my third one is so there's an annual financial evaluation and then a 3-year eligibility reevaluation. Is that primarily, in the case of autism, done with just a Vineland?
Yes.
So I guess I'll do one more follow-up on that. As you know, I've done thousands of Vinelands by now or evaluations, and I almost always do the Vineland just kind of as a preparation with the family as to the questions to get them used to that type of question to allow them to evaluate their child's actual behavior instead of what they can do with support. So, do you feel that that's and maybe Elena can also jump in on this, best practice, or because I have seen them inflate their child's abilities so many times when indeed, when I see them, the child is not doing these things independently.
Yes,
Thank you.
that's a great point. And if that's an exercise that you can do with them as they're going through that process, I think that's great because it helps them realize what they can actually do with those questions. Your Vineland won't be used by Liberty Health. They have to do their own Vineland, which is something that sometimes frustrates parents because they just went through that process. But they're also going to do that in an interview format where they're asking those questions. But I tell parents to think about your child on the worst day because you're right. They often do say, well, I've seen them do that once, but no, do they do that regularly without prompting, without any help? And it can be a hard thing for parents to continually say, no, we can't do that. No, they can't do that. And so any preparation you can give them for that interview with Liberty Health, like this is just to open up a door for services. This is not like something to make you feel bad about what your child can or can't do, but we need to be super honest with ourselves about what our child's ability is so that this can open a door up for all the services that could potentially help your child. So I think that's a great point. Yeah.
Thanks, Julie. Let's go to Travis, and then Brian, I see your hand up as well.
Brian, go ahead. I have a clarification, so shoot your
So
question.
one of the things that I will frequently do is talk with parents about the Vineland, telling them what to expect. But then also I coach them in the way of saying, imagine your child is transported to a family that loves them like you do, but doesn't know them like you do. Answer the questions in that regard because you've created an environment that adapts to the needs of your child, where some of these behaviors may not come out. But imagine if they went and spent 2 weeks with an in-law or a sister or something like that, and they didn't do all these things, then what would the behavior be like? Because I've had a number early on where parents were like, they failed or not failed the Vineland. They did not meet criteria because of the Vineland. And I'm like, what are you talking about? And then we talked about it, and they're like, well, they asked about this, and I said this. And I'm like, but what if your child was with me for 3 hours? Would they still act this way? And they're like, well, of course not. And it's like, well, that's how you have to answer. So I think that's one way of coaching that can be really helpful. That's still genuine. You don't want to coach them to be dishonest, but you want to coach them to be genuine. And that's a way that I found that's useful.
I like that. That's a really helpful lens to have them look through.
One other thing I wanted to mention about this is I give the Vineland every single time with every single one of my assessments. I don't do the full comprehensive interview for a variety of reasons, but mainly because of time, but because Liberty's going to do their own. But I do it as a way to kind of screen for the potential for them to need services, because we know just because they have an autism diagnosis, and I see a lot of the older kids, they aren't necessarily going to meet qualification for Katie Beckett. They aren't necessarily going to meet qualification for services. So I do it as kind of a screen, as a way to kind of let families know, hey, there's likely that there's going to be likely they're going to potentially qualify for services just by their scores in these domains. The other thing that I also use, Brian, I like your analogy about if it was another person. This is a parent rating measure, though. So we're wanting to get parents' perspectives of their child versus another person's perspective of potentially what they may or may not do. So kind of still keeping it as the parent perspective is important. But the other thing is, I just say, if your child was in a room by themselves, and they had to do this stuff, what would they do? Or if your child's older, if your child was left to their own devices, would they do this on their own? How frequently would they do it? And I like to use like the 80%, 50%, less than 20% type of marks to help families rate their child. So that's just my 2 cents.
Really, I wanted to quickly clarify and then maybe get your professional direction from maybe what these 2 programs run. So quickly, Katie Beckett pays into a Medicaid funded support, and you have a column of services that rest inside that support, i.e., the developmental disabilities program, correct?
Mm-hmm.
And then you also have the Vineland, or you have behavioral supports that everybody can access, but they have to, in this case, do the Vineland in order to show criteria to gain those access to those behavioral supports.
You said everyone. You mean everyone with Medicaid?
Everyone across the state has access to a behavioral interventionist through a facility that offers that service.
Through Magellan. Is that what you mean?
Yeah, like if they have Medicaid, they can access this.
Because you have to have Medicaid to access any of the developmental disability programs.
Correct. But there's also a BI. So in your last slide, you had RPT and BCABA and then
Yep.
the BCBA, and that is the developmental screening, or like that's in the Medicaid support, right? And then the BI is outside of that. Is that correct?
No.
From your understanding?
So the behavior modification, yes, okay, I see what you're saying. To get access to behavior modification or behavior intervention, which is called different things, but it's essentially the same thing, working on those challenging behaviors, you can access it through the developmental disabilities program if you have Medicaid, yes, or through Magellan if you have an autism diagnosis and if you meet all the other criteria, which I don't have outlined.
Within this, yeah.
Yes.
And then so as a BI and an RPT, the same person, the same training.
So in the state of Idaho, behavior intervention can be provided by people with a number of different levels of education. Like I, as a BCBA, through the Developmental Disabilities Program, provide behavior intervention. So it can be provided by an evidence-based model professional. It can be provided by a developmental specialist. Like there's a variety of different tiers of education that people have to provide the same service. So that's a good question for parents to ask the agency that they go to or the independent provider. Like, what's your level of experience? What level of provider are you? On the behavior modification side, a registered behavior technician does not have the same level of experience and education as a BCABA or a BCBA. So those are just different tiers in terms of level of education and experience. An RBT is typically working toward becoming a BCBA.
I'm glad that you're in line with my disconnected thinking and can like better phrase how I was trying to get that question out. Lastly, so from a coaching model for a PCP to come to a parent as they're supporting that parent to go through Katie Beckett and look at these services, part of that coaching would be to make sure that the PCPs having the parent advocate to, hey, what role and training have you come to this spot to be in? Because there seems to be so many ways to get there. And the parent should have education as to like what they may want for their child.
Yeah, and sometimes there's a fit like goodness of fit, right? And to determine like, is this going to be the right provider for us? But often in our state, the wait lists are so long. Sometimes parents are just excited to get any service, right? So they're going to compromise and take whatever they can get. So it's nice to have a conversation with them, like, you know, is it better to take this, whatever you can get? Make sure whatever you can get is appropriate for what you need and is a good fit for your child and is going to make a difference. The parent should be a part of the decision-making process in terms of what the goals are, and they should be well aware of all the procedures that are going to be used. And especially if appropriate, the child should be a part of all of those decision-making processes as well. And then monitoring if it's working, like, are we making progress? What does the data tell us? What's going well? What should we change? I didn't like how that went. It's a really important conversation to have. Thanks, Lindsay. She just put in the chat. We put together a little resource guide around how to coach families to ask questions about their providers and how to figure out if that fit is appropriate or not. Elena, the services are pretty similar in terms of scope. They're just going to use different billing codes. Behavior intervention can address maladaptive behaviors to try to decrease them, while also working on habilitative skill intervention to increase those replacement behaviors or activities of daily living, all of those skills. Behavior modification is going to do something similar.
I'm still trying to clarify as I talk with families and as providers talk with families. There's the insurance coverage bucket. So who's covering it? And then once we decide who's covering it, then what are our options in terms of like behavior-based strategies? So we've got commercial insurance where maybe they don't quite, I don't know why they wouldn't qualify for Medicaid or Katie Beckett Medicaid, but maybe they don't, maybe they don't want to go that route. So you can seek out ABA type therapists
Yes.
through commercial insurance.
Yes.
And then there's Medicaid. And then under the umbrella of Medicaid, and you have a child who may or may not have autism, but can still tap into BI services.
Yes.
Right?
Yes.
So some of those kids may have autism and tap into BI services. Some of these kids may not, and there may be other qualifying diagnoses or qualifying reasons, and they can tap into BI services.
Yes.
And then you have a child with autism who could also tap into behavioral modification.
Yes.
Through Magellan, what used to be Optum.
Yes.
All right. And the quality of the services for, like, say, a child who has autism who isn't doing through Magellan, but is doing through BI services, it would basically be the same providers. It's just a different billing.
It could be, yes.
Okay.
Yep.
Okay. All right. Okay,
Yes.
that's helpful. Thank you.
For families
yeah, we had a question from Preston. I'll just read it. So for families interested in case management, can they ask Medicaid or health and welfare staff about that, or does it have to? Does it often need to be sought out through other agencies or companies?
No, case management is going to be assigned from the department. So if you contact any of those regional hubs and say you're interested in case management to help you get through the Katie Beckett process, then they can help you assign you a case manager. Yeah. But the agencies don't provide case management. I know that's confusing. But it's through the department directly or their contractors. Yes.
I think it's so nice to have extra time with you, Julie, to do a Q&A. We also have another question that came in. Can families already receiving ABA through private insurance then transfer to Magellan for financial reasons?
Yes.
Okay. Hi, Tom. And we're going to if we have other questions directly for Julie, but also this is a time that we can ask those broader burning questions. Use that time this time for those questions as well. Okay, all yours, Tom.
Well, I just wanted to also add the resource of Idaho Parents Unlimited. They have a really great organized infographic and um, resource list for families to apply for Katie Beckett. And I've had families contact them and get incredible support. So again, Idaho Parents Unlimited, their website is great. I can put it in the chat if y'all want the link to the Katie Beckett stuff.
And I think from time to time they give webinars about it too. And yeah, they're a great resource. Thank you, Tom. Tom, I'm going to tell you that I encouraged our swim instructor this summer to have my daughter's swim group come at least one day all in their clothes. And it was a really interesting session. Some children were very uncomfortable being in the pool in their clothing, and some kids just acted like it was another day, and some kids really struggled with having jeans on and the feeling of it in the water. So I want to thank you, because that was I think a really important session of our swim instruction this summer, because the class my daughter is in has a lot of other children who have autism. And so that was pretty awesome.
Yeah, my heart is heavy this week because we had a tragedy with a 5-year-old who I highly suspect had autism, nonverbal, and delays, who drowned in a canal. And so I wonder, I mentioned safety here, but I wonder if we need to mention some safety in another forum where it would get to the public. And I don't know if that's our responsibility as Idaho WAMI Echo or not, but that's been weighing heavy on my heart this week because, it's just so critically important. And I have so many families say, oh, but he's always under my eye. And every one of these kids that die, and under 5, the mortality is 50% if they're a wanderer and they seek water. If water is one of their sensory things, the mortality is 50%. So it is, it's real. And this case this week just really, I think, weighs heavy on all our hearts. But I will not stop reminding everybody about swimming. And I love the feedback on the swimming in clothes, because I just think that's vital, because, not all kids wander in their bathing suit. So
I also hear there, Julie, is to educate and advocate for parents whether the swim instruction is directed towards that, but to ask and to encourage and advocate to potentially have a swim instruction to those things, to have clothes on or to look at those safety things available to them.
Yeah, it wasn't something that they had done in the past. So
yeah,
but everybody was on board. All the parents were really interested in trying it. And so I'm really glad we did it.
That's such a cool story. Thank you, Julie, and the heartbreaking part of it, Tom. What other questions do we have for Julie or our panel? Specific, our cohort members, if you have any questions, you're welcome to ask those right now.
I have a question.
Oh, good. Thanks, Shauna.
Yeah. So I know the wait lists are getting longer and longer at St. Luke's and at Northwest Behavioral, and I know we're trying to help the younger kids, but what about the older kids that I need to get in? Where I know there's like GPS and Meridian, like other places popping up. I guess I wonder what sorry, it's loud here. What people would recommend as good places to send people with insurance, with Medicaid, that don't want to wait 1.5 to 2 years.
Is it okay if I chime in on this? We don't specifically, as part of an ECHO, we can't specifically give recommendations for specific places. But I think what's important, so I see the majority of the older kids. I've been seeing, like, that's primarily my population as of late. And so what I'm saying is I feel like I can speak to this, not saying, it's my thought is in terms of some of the tools that are made and that are used, and then how that information is integrated. So, think about some of the things that you're learning as a cohort member in terms of integrating your information, getting a good history, using the tools that you have at your disposal to answer those questions, and then be able to integrate it in a way that that really seems to make a case. And I mean, those are the type of and folks who can provide very relevant recommendations. So if you have somebody who's diagnosing a child with autism, but yet their recommendations don't seem informed as to how to address, the unique things that that person, that child is experiencing as it relates to their autism, then it applies to me that they don't have a lot of experience with diagnosing and doing like treatment planning evaluations for autism. So I would look at those kinds of things that you are learning, and is it applied similarly to older individuals as well? So we use the same standard of care regardless of age, and getting a good history, using a tool like an ADOS or a STAT or something where you have some real-time observations, and then providing recommendations that seemed very relevant to ASD. Those would be kind of the three things that I would look for in a community provider. I'm sure other people might have other input.
I wanted to add to that Dr. Harlan, from the site of diagnosis and getting into some of these longer wait lists in order to do that the need for intervention can start, I think, in what Harlan was kind of help coaching to make sure that interventionist has that informed direction of what that potential diagnosis or neurodevelopmental struggle might be, but to move those folks into those interventions at like right away, understanding that some of those interventions may be specific to the diagnosis in the sense of like pay, like these Medicaid piece might have to have a diagnosis in order to get some of the services, but there are services still available in the community. We could still get a speech therapist involved with 100% of those patients, older, younger, to begin some pragmatics or coaching with speech and language. Jamie can probably have some direction on that too. Psychotherapy, talk therapy, depending, cognitive behavioral therapy, depending on their cognition, even parental, marriage, family therapy. All those can begin and start to help, especially those older kids can have big impacts with inside the family or come with a majority comorbid diagnoses. And as we go through this cohort, we'll have little snippets and sprinkles around those comorbidities and helping those out while waiting or getting into a diagnostic evaluation across the state of Idaho, because I think north is even longer than southwest and so on and so forth. So I think advocating for those things to start is real important.
I would just encourage everybody to continue to invest your energies in learning how to diagnose autism in that age group. And you can do it as a primary care provider in Idaho. And I think it's easier for us to learn how to do it than to grow a developmental specialist. That is a long commitment. Developmental specialists come out of fellowship training, and they're hired up immediately in big cities. And we have somebody who had a specific desire to be in Idaho, and that's the only way we can get another developmental specialist, is someone who has a desire to be here because they have someone who loves them here, or they love somebody here. So in any case, I really encourage y'all. It's a very important age group, and it can be very rewarding to help these kids. And I would just say, in the waiting, always make the intervention referrals as you're waiting, because you can never go wrong making those referrals, OT and speech and PCIT in the right age group. I've even had kids that don't have autism that I've been able to get ABA for. And so, make those all the referrals you would make, and then work towards comfort with diagnosing those kids yourselves. It's something I used to refer all of those kids to behavioral pediatrics, and as the wait list grew and grew and grew, I decided to change it and learn how to do it myself. And now I have a wait list, sadly, that I'm trying to figure out how to get around myself. But it's a good problem. When I started the clinic, I didn't know whether it would be successful, and now I'm booking out quite a ways, and so we're making an impact. And if we can replicate practices that are doing that in other clinics, we will make a move on the long wait list, and the kids who are ambiguous can get into the developmental pediatrician. And I'm not just picking on you, Shauna. It's my hope for everybody, because it's such an incredibly rewarding journey to become, it's kind of autism aware, and then, autism action, and then autism access is, I think, the way that it happens.
I think the hope, Tom, is that like by primary care providers being able to really identify the kids when they're younger, then we don't have to wait until they're 12 to identify them. And there is a statistic out there. I think I was attending a virtual conference, looking at kind of autism diagnosis and kind of the state of things. This was probably about 2 years ago, and there was a psychologist or neuropsychologist presenting from Connecticut, and they have an autism center there. And she said that generally what's happening, and every clinic has their own kind of level of screening in terms of who they will see for autism. But she said for adolescents presenting with social concerns to their clinic, and of course they're autism specialists, they're only diagnosing 30% of them as autistic. So that means 70% of any kid who comes to you for like an annual visit and they're wondering if they have autism probably won't end up getting an autism diagnosis. And so these kids are hard to diagnose. They're incredibly challenging. And it takes, multiple hours, interviewing, making sure that parents are able to reflect back on what they were like when they were younger. And oftentimes that's hard. Using your own pattern recognition when interacting with the child, looking at all the other potential rule outs. We know there's a ton of different other differentials to think about. And so if for anyone who wants to work with the older kids and wants to diagnose them, then we encourage that. We would love that. But I also think it's a lot. And getting really, really well versed in the young kids and kind of starting to look at that trajectory over time, what might they look like when they're older, can be super helpful, because starting just with the older kids can be very confusing. And so kind of understanding the kind of developmental trajectory could be really helpful as well. So that's just my 2 cents. It's just a really tricky population that has a lot of other things going on as well that are worth kind of examining and exploring.
Yeah, I think you're right. It seems like they've like found ways to handle it too. And then it looks like this or that, and it looks like they're just anxious or they have ADHD, but really, it takes a lot of time to kind of unravel. And I had one yesterday, and by the end I was like, you ever thought maybe you're on the spectrum? And a lot of them are like, yes, thank you for finally saying that. And I was wondering, are there any good like online tests teenagers can take to because they love to Google and self-diagnose, and I wonder if any of them are actually good that you know of.
I think from a provider standpoint, like in terms of, there is something, oh gosh, I have to make sure I have the acronym correct. It's from Baron Cohen. Let's see, was it the ASQ or AS, the autism symptom, or is it AQ? I think that's what it is. I think it's a measure that you can use in adults as well. I think it's AQ autism.
Yeah, I think it's the AQ
The
self-report.
AQ like self-diagnosis test. So
Yep.
it's autism spectrum quotient. So I think that's something that probably, I think that's been around in the public domain for at least 10 years, if not more. So I think that that's the first step. And I think for providers who are doing these evaluations, the more, and I know you all are very, very limited in terms of how much time you have to gather information, but the more you can gather information or get a checklist, get a sense of the symptomatology to pass on to in the referral, like the better. I know some folks are using like the CAST, which is also out of, I think, Britain, but that's helpful. The MChat, of course, we've talked about that. Trying to think of anything else in the public domain that you can use that's free. But those are some of the things that are helpful. It's better than just saying patient wonders if they have autism without like any data to kind of support that. It helps us a lot.
And I think sadly there's some social media influencers that are now aggrandizing an autism diagnosis. And I think for some of them, it probably explains away their introvertedness. And I think it's a lot of the self-diagnosis. And so it's really fascinating when I'm going through the end of a visit with these kids, I'll start going through the A1, A2, A3 criteria and then get into the B, and you start seeing them for the first time, like avert their gaze, like, I haven't been looking at you for the last hour and a half. And then they're like this. And, they start exhibiting like within, 5 milliseconds of me stating what would be a criteria for autism. They start exhibiting it for the first time in an hour and a half. And so it is a tough group. And I don't know, I was blessed that the doctor who I replaced almost 27 years ago here in Idaho told all the patients I'd had extra training in autism, and I had exactly what my residency program had taught me about autism. And then I learned a ton from the patients. And I've had some really great parent teachers over the years.
Gwen, do you want to jump in, please?
Yes. So before I ever see anybody, I have, especially the adolescents or an adult, I like to see their social responsiveness scale, and hopefully one completed by a spouse or a coworker or a parent rather than the child themselves. Going back to what you said, Tom, yes, lots of adolescents will Google the characteristics and then try to imitate them, and or the parents just trying to figure out what's going on. And during an intake interview, they will just kind of go down the checklist and say their child has that particular disorder. But especially females are tricky. I've learned to love that age group, that 5th grade through 9th grade age group. They're very challenging, but getting into where the social demands are exceeding their skill level, that's when you can really start to separate out those who have autism versus those who don't. And when we talk about, friends and friendship network, going to birthday parties, getting invited to birthday parties, thinking about relationships, you can really separate out those girls who are trying to mimic versus those who are actually just saying they have the autism. So you can separate that out pretty quickly if you have that early understanding, like Elena was saying, like understanding the child and then seeing how that progresses into childhood and adolescence.
And then there's always something that I like to talk about called the broader autism phenotype, where sometimes you have traits and features of autism, or you have a sibling who has autism, but you don't quite meet criteria, and that's okay. That doesn't mean that these experiences aren't something that you're having. And just trying to kind of say, sometimes you can have traits and features, and here's kind of some of the things that we do to address those things. But and yes, you can have some challenges, and that's okay. And you don't necessarily have to have a diagnostic label to validate that. So that's the other thing that I find a lot of times I am with those kids who I don't diagnose, who are really on the edge for me. That's a really common conversation that I'm having with them.
Do you want to chime in, Tom?
Sure. I had a fascinating case last week where it was a 13-year-old trans male who was in for a diagnosis of autism. And it was challenging for me in that I was seeing a Gestalt language style that shone through the transition. And this kiddo met all criteria at 13 as a trans male, but it was just interesting to remember that girls will have a Gestalt language style oftentimes, and they'll learn to cover up their autism and mask it better than boys do. And so, anyway, it was just a fascinating case. And then I had another day where I had a 3-year-old autistic kid and a 3-year-old neurotypical kid back to back, and it was so interesting because at 3 you could just see the social blossoming of the neurotypical kid versus the 3-year-old who really had very difficult social interactions. And so, like, comparing and contrasting same age autistic versus neurotypical, it's really incredible to look at that juxtaposition of the two kids. And then also, I hadn't ever encountered a trans patient that had exhibited their biologic, phenotype of autism. So it was really fascinating.
Well, thank you for this wonderful conversation. Plenty of Q&A time. I hope that you all appreciated that extra time today. We are going to meet again August 22nd from 12:30 to 1:45 Mountain Time. And the topic for our next session is going to be role of occupational therapists in working with children with ASD. And we have a guest presenter, Dawn Yearsley, who is a colleague of Jamie from Northwest Neurobehavioral Health, joining us. And then one more plug for our STAT cohort 2. I'm looking to secure our patient cases for October 10th and October 24th. So if you are able to present on either of those dates, reach out to me. Hong Yan has placed information for you to claim your CEs, CMEs in the chat. Thank you. If you have any questions navigating that process, always reach out to us. Okay. Thank you so much for a great conversation today. See you on the 22nd.